Next, I would like to review the duodenal switch operation. We started with the normal anatomy, and from normal anatomy to the sleeve gastrectomy, we noted that the small bowel stayed the same, and the only difference was removal of the 75% of the stomach in a scaled fashion. Going from sleeve gastrectomy to the duodenal switch operation, we can immediately notice that the stomachs are identical, which means that 75% of the stomach is removed in a scaled fashion, and the food travels down the esophagus into the small bowel. Again, Happy Meal number 1, small fries and a lemonade. It will sit in the stomach with the pyloric valve closed. While the pyloric valve is closed, there are certain chemicals that are added from the wall of the stomach into the lumen of the stomach. This allows food to be broken down into proper absorbable components. And when everything is chemically properly set, then the pyloric valve opens up, and then food travels down a length of the small bowel. As the food travels down the length of the small bowel, there is a different segment of the small bowel that will bring the juices down from liver and the pancreas without allowing it to mix with the food that's coming down from the stomach. And it's only at the very last segment of the small bowel that the juices from liver and the pancreas are exposed to the food that's traveling down. As with the previous two discussions that we had, if we go back and ask ourselves the question, what gets absorbed when the food is mixed with the juices from liver and the pancreas? The answer would be fat, protein, and the carbohydrate gets absorbed. The food traveling down the small bowel will only allow for the absorption of the carbohydrate. And the segment of the small bowel that carries no food and only the juices from liver and the pancreas will have no absorption of any food content because there's no food traveling into it. We can say that the segment of the common channel, the very last part, is approximately 5 to 10% of the total length. The alimentary limb, this segment of the bowel, is approximately 40 to 50% of the total length. And the part of the small bowel that we have rerouted to eliminate its absorption of the food is approximately 50% of the total length of the small bowel. So when we go from normal anatomy to the sleeve gastrectomy to the duodenal switch operation, we are not removing any of the small bowel out of the patient. All we're doing is rerouting the GI tract in such a way to limit the size of the absorption, to limit the patient's ability to absorb as much calorie and fat and the protein as they may be consuming. So going back to my normal anatomy discussion, if a patient eats a Big Mac fries and a Coke and that allows them to consume 1,000 calories, they will be absorbing approximately 1,000 calories. With Happy Meal number 1, with the sleeve gastrectomy, your consumed calorie is 400 and your absorption is approximately 400. With the duodenal switch operation, since the stomach is identical to the sleeve gastrectomy, the amount of calories taken in is 400 calories, but the food only travels down approximately through 50% of the length of the small bowel, so your absorption is less than what you would be with the sleeve gastrectomy. Again, just going back to one of the disclaimers that I said earlier, these are oversimplification of the facts. I don't think anyone should answer any questions on any test based on this information, but this is to keep things very simple in a very short segment of time. So normal anatomy, a certain amount of intake and the absorption equal to it. With the sleeve gastrectomy, much less intake, much less absorption. However, the numbers are equal. With the duodenal switch operation, same intake as the sleeve gastrectomy because stomach sizes are similar, but the absorption is a lot less, in the vicinity of about 50% of the calories, because we are only utilizing 50% of the small bowel length as exposure.